Thank you, Jenny. Thank you for coming. This is, for me, quite an important topic, but I recognize that this is quite a niche topic. And I'm really pushing boundaries to tell everyone that ultrasound should be used on a daily basis so that we can reduce maternal morbidity and mortality on all aspects in pregnancy care. And now we're covering some aspects of postnatal management as well. The data that I will share today are largely unpublished, so really presenting for the first time our research results, and I will share with you some of the tools that we have been relying on in relation to Samsung support. Our disclosures, but let me start off. I know you've perhaps come from care process lecture, and then some of the work will be reproduced here in terms of preeclampsia screening. We are all in agreement that we should be adding biomarkers, blood pressure, placenta growth factor, and uterine artery Doppler to maternal factors in order to achieve better prediction for both preterm and early onset preeclampsia. And then because, as you can see, if we just take a history, asking for a number of risk factors, and we are only achieving half of the detection rates for these two types of preeclampsia. For term preeclampsia, there's much work to be done in order for us to improve the prediction. And in terms of the three biomarkers, I'll touch on the measurement of blood pressure. You may say to me that this is not what you want to do. Yes, it's okay, but take down the protocol and share it with your healthcare providers, and then they can measure blood pressure according to our protocol. Because we're providing screening, we're providing accurate screening, and we don't want to give a low-risk report to a high-risk woman and vice versa. And therefore, every aspect of our screening model should be well done. And therefore, based on data of 25,000 pregnant women, we've developed this best practice approach in measuring blood pressure for the context of preeclampsia screening. Then in relation to ultrasound, of course, we're here at an ultrasound conference, and therefore we must emphasize the use of ultrasound. But I'm also mindful that the uterine artery Doppler may not be applicable in certain parts of the world, especially in Asia. Anyhow, we have a standardized protocol for measuring uterine artery Doppler through transabdominal ultrasound. I will not dwell on the methodology here, but then you're welcome to take a picture of this protocol that has been endorsed by ISWOG as well. Then, in relation to taking what we did in Europe to Asia, the first work that I did was to validate the triple test, because care process like, well, in Asia, patients are different, women are different, perhaps we need to validate that the triple test works equally well in Asia, and therefore we embarked on this journey by including 10,000 women with single-day pregnancy across the region, and this is the work of my previous PhD student from Thailand, and then we've demonstrated that. The pink bars are the Asian data, the blue bars are the FMF East Asian data, and very comparable results. But the most important thing that I want to remind everybody is that on the right-hand side, we did a head-to-head comparison of the FMF triple test against ACOG and NICE recommendations, and you can see that the FMF triple test is superior in terms of screening performance when compared to the ACOG recommendations and the NICE recommendations. So this is a very important message. We can't just simply take a number of risk factors from the pregnant woman. We must add a number of biomarkers in order to achieve better prediction. Again, this is perhaps work that you are very familiar with, but just need to set the scene in terms of the work that we have really focused on over the last 20 years. We have a prediction model that identifies a group of women needing intervention. And then for these high-risk women, we gave 150 milligrams of aspirin from 14 weeks till 36 weeks. And you can see that we can reduce the rates of early onset preeclampsia by 82% and preterm preeclampsia by 62%. A very important message is in relation to compliance. I think this applies to all drug treatments, is that if you have a high level of compliance, then the treatment effect will be better. And if a patient achieves 90% of compliance, meaning from 12 weeks till 36 weeks, we give them all the tablets, and then 90% of all the tablets are taken, then we can even achieve better prevention. And we've replicated this work in Asia, across 10 regions, including 18 centers. This is the work of another student of mine from Vietnam, and then this QR code can take you directly to the paper, which is open access. But the most important message here is that in the real-world setting, by implementing the first trimester screening method and then identifying high-risk women, giving high-risk women 160 milligrams of aspirin, we can effectively prevent preterm preeclampsia by 40%, early onset preeclampsia by 50%, a composite of adverse outcomes needing delivery before 34 weeks by 50%. Additional benefits that we didn't show with the aspirin trial was that we were also able to reduce the risk of perinatal death by 66%. And for spontaneous preterm birth for no reason, by 55%. So these are the collateral benefits, and I think this is also very helpful for the pregnant women to decide on taking a drug, because they don't necessarily think about their own health, they're always worried about their children's health, and therefore, I'm afraid this is a bit of making sure that they will buy into the screening and prevention program. Now, moving on, in relation to the heart, I think you've heard Baski and Stefan talking about what is to blame. Is it the placenta or is it the heart in relation to preeclampsia development? The simple answer is, of course, both. Not just one, not just two. And then, so what I'm just showing here is that we've seen overlapping between evidence of impaired placentation and evidence of cardiovascular dysfunction when we have cases of preeclampsia. So I will share more data in relation to that. And then this is a very important slide, just really highlighting that we've learned that, first of all, preeclampsia is an independent risk factor for adverse maternal cardiovascular outcomes. But then, is it a chicken egg situation? Is it the heart first, or is it preeclampsia first? Or whether it's a combination of the two? That remains to be determined, because it's actually very difficult to do pre-pregnancy cardiac work. But I know the group of Christoph Lees really attempted to answer the question. And then he showed that actually for women who are destined to develop preeclampsia before pregnancy, there's already evidence of cardiovascular impairment. So, and then here I'm just showing the different patterns of abnormalities in hemodynamics in relation to development of early and late onset preeclampsia. And this study really highlights the profound abnormalities in cardiovascular function in those who would subsequently develop preeclampsia. So a bit of normal physiology on the left, and you can see that over the pregnancy period, in a normal intensive pregnancy, you get rising cardiac output. You get reduction in the systemic vascular resistance. This is to accommodate the pregnancy. Okay, and then there's already a huge body of evidence, and this slide really summarizes the results from a meta-analysis of 36 studies, including 745 women with gestational hypertension without proteinuria, 815 women with preeclampsia, and over 7,000 normal sensitive controls. And this work is important because this work didn't just look at hemodynamics, cardiac output, systemic vascular resistance. It also looked at cardiac structure, geometry, systolic and diastolic function. So the first box you can see, and then during pregnancy, women with preeclampsia, gestational hypertension, you can see profound increase in the systemic vascular resistance that is actually reflected in the high blood pressure. Okay, when it comes to the geometry of the heart, focusing on the mass of the left ventricle, again, you can see that both preeclampsia and gestational hypertension, then both of them have increased left ventricular mass. In relation to systolic function, as represented by ejection fraction, I'm sure this is something you're more familiar with, but there are no differences between the three outcome groups. But when it comes to diastolic function, the resting function, yes, you can see that the E to A ratio is significantly reduced in both preeclampsia and gestational hypertension. I need to declare I'm not a cardiologist. Okay, I'm not a sonologist. I don't do echo. I can do basic targeted echo evaluating hemodynamics. So basically, a lot of the work is led by my PhD students who are sonologists with expertise in maternal echo, and then I want to give them the credit. And then This is a video demonstrating to you the hemodynamics evaluation. The hemodynamics that we focus on: cardiac output, stroke volume, systemic vascular resistance, and the equations that can convert these parameters measured by maternal echo. Here we are measuring the velocity time interval, and then with that we can multiply. Very complex equation. You can copy that if necessary. Can you imagine? I mean, I started doing this 20 years ago when I was at Harrisburg, right in London. I remember staying till 11 p.m. every night doing all these scans and manually calculating stroke volume using this equation, measuring the VTI and the LVOT, which is the diameter of the left ventricular outflow tract, and calculating cardiac output and systemic vascular resistance. It was painful. And now we have AI solutions. And so the first thing I ask Samsung, is it comparable? It's very well that you tell me that the heart assist tool is allowing me to measure cardiac output, systemic vascular resistance, etc. But then obviously I'm the goalkeeper. I'm here to make sure that if I were to recommend something, it is clinically valid. So we did a comparison study between the manual measurement of the VTI, remember, is one of the components to generate stroke volume and therefore cardiac output. So we did a head-to-head comparison of manual appraisal of VTI versus heart assist, and the difference is tiny at 0.3. So very, very convincing that we can definitely use AI to measure VTI. And that process is much quicker now, yes? And these are some initial results. We've just published these results, trying to figure out at 12 to 15 weeks. Why do I extend to 15 weeks? Because, we keep talking about 11 to 13 weeks plus 6 days. But I'm also mindful that pregnant women don't always present in time. So I'm hoping that I can have solutions for those who miss that 11, 13 weeks time frame window, and maybe I can then provide additional screening between 14 and 15 weeks so that I can still offer aspirin to high-risk women. And in this study, we were trying to figure out whether hemodynamics at this 12 to 15 weeks time point, could the parameters be used for prediction? We've identified that women with preterm preeclampsia, any onset preeclampsia, so delivering at any time point, there was significant reduction in stroke volume and cardiac output and a significant increase in systemic vascular resistance. However, we were not able to see benefits in terms of prediction, but that doesn't put us off in evaluating hemodynamics, because we're wondering, well, it may not be useful for prediction at 12 to 15 weeks. Perhaps we need to use it for monitoring and see whether women, high-risk women treated with aspirin, and some of them have preeclampsia, some of them don't have preeclampsia. Are the hemodynamics different between the two groups? So we embarked on looking at longitudinal data, which is not easy to do. We followed the aspirin protocol. I mean, all our high-risk women treated with aspirin, without aspirin, are invited for a follow-up study, and we saw them at 20 to 24 weeks, 30 to 34 weeks, and 35 to 37 weeks. And first thing we did was to look at something very simple, mean arterial pressure. And then the red line represents high-risk women treated with aspirin and yet developing hypertensive disorders of pregnancy. That is a composite name for both preeclampsia and gestational hypertension. Interestingly, high-risk women without HDP, although the blood pressure was a bit lower, but the line, as you can see, as represented by the blue line, is higher than the low-risk women. So I'm suspecting that these women are still at risk of future cardiovascular impairment, but not as bad as those with HDP. But you can see the trends between the three groups. And we also evaluated hemodynamics during pregnancy. It's very busy here. And then we looked at stroke volume, cardiac output, and systemic vascular resistance. We found that the low-risk group had a higher stroke volume. The high-risk group, with or without HDP, actually stroke volume was very similar, as shown by these lines here, and cardiac output was of a similar pattern. And when it comes to systemic vascular resistance, you can see that the high-risk group with HDP had the highest systemic vascular resistance, and during the second and third trimester, the values are quite stable, and then the high-risk group without HDP had the intermediate line, and then the low-risk group had the lowest systemic vascular resistance. Physiologically, we need to see the drop of systemic vascular resistance to accommodate the pregnancy. So now I'm going to share with you the results beyond pregnancy. And then you call it the fourth trimester pregnancy. And all of you obstetricians, maybe, yes, hopefully. And then, and I remember when I was a trainee, I said, okay, I deliver the baby. I hand the baby to the pediatrician. That's my job done. And then I was like, okay, by 6 weeks, you will be back to normal. No concern. And then I really had the strong belief that everything would normalize, even cardiovascular function. And then I will share with you some shocking results, and with the support of Samsung. And this is a work in preparation for publication. Hemodynamics, as I mentioned, stroke volume, cardiac output, systemic vascular resistance. I'm showing you the mean arterial pressure here and the systemic vascular resistance here. So there are 3 groups here. The black line represents low-risk women with the lowest mean arterial pressure and the lowest systemic vascular resistance at 6 to 12 weeks postpartum, okay? The blue line represents the high-risk group with HDP, and then the blue line represents high-risk group without HDP. Can you see that for those having had a hypertensive complication in pregnancy, throughout the postnatal period, up to 1 year, the blood pressure doesn't normalize? And for me, that is something we mustn't ignore, because 6 weeks, I'm sure you would discharge the patient to the community and say, off you go, even though you don't need antihypertensive treatment. Yes, this is not at the level that the woman needs antihypertensive treatment, but I'm actually quite shocked to learn that, 140/90 defines hypertension, right? Yes, 140/90. Do you know where that number has come from? Purely male data. That value predicts future cardiovascular morbidity. For female, the cutoff is 120/80. So this is a wake-up call for us to recognize that we've been working and relying on male-specific data, defining hypertension as 140/90, because that value would predict future cardiovascular morbidity. But for women, our cutoff is much lower. And so if we forever rely on 140/90 for treatment, then we are actually we're not doing very well in preventing cardiovascular morbidity in women, because we know that it is also the number 1 killer amongst women. So, and on the right, systemic vascular resistance, again, the low-risk group had the lowest systemic vascular resistance, and then the intermediate risk group, yes, which is the high risk without hypertensive complication of pregnancy, had a higher systemic vascular resistance, and then the red line obviously showing very high value. And you don't see normalization by 1 year postpartum. You think that these lines will come down to a low-risk level, but then they don't. And for me, that was a wake-up call that we must put in place a program for postnatal health management. And just so to give you a sense in relation to the heart, can you see the left side? That heart belongs to a patient who subsequently developed preeclampsia. This is not at the time of preeclampsia, but can you see how thick the myocardium is? Okay, so I mentioned about the geometry, increased left ventricular mass index, etc. So this is what I call pre-heart failure feature. And then again, this is something we mustn't ignore. And so we relied on heart assist to measure the left ventricular mass index. So this is taken at the parasternal long axis view, which is used at the beginning of the examination. The patient is usually on left lateral position, arm tucked under the head, and we place the transducer in the 3rd or 4th intercostal space at the parasternal border, literally here. Okay, that's where we get the LVOT. Let me play this again. Oh, if I can. So what we do is we use M mode, and we place the M mode just at the tip of the mitral valves. Okay, and we do the scan according to the American Society of Echo guideline, and then we measure the interventricular septum, and which is here, and we also then measure the interventricular internal diameter, and then we look at the posterior wall thickness, all contributing to the LV mass index measurement. In the old days, we need to do that manually, but now we are very lucky that we have this tool, which is automated. Can you see? Everything is measured within seconds of the scan, and this is really making our work much faster. We can do a comprehensive echo within 20 minutes. So this has really revolutionized our work in this area. So that's, again, AI, can I rely on it? And so we did a head-to-head comparison between manual and automated measurement. Again, the difference is tiny at 0.6. So conclusion is that we can rely on heart assist for evaluating the geometry of the maternal heart. So these are the results of our work over the 1 year postpartum period. Again, the red line belongs to the low-risk group. The blue line represents the high-risk without HDP group, and then the red line represents the high-risk with HDP group. So you can see after birth, after delivery, the left ventricular mass index is substantially higher in both high-risk groups, and obviously with the HDP group with the highest values, and then you don't see the normalization to the low-risk group. So again, after 12 months postpartum, and then you don't see complete normalization. And on the right, you have the right relative wall thickness. Again, similar results that both high-risk groups had high values of relative wall thickness, but actually with the HDP group, with a slight increase towards the end of the first year postpartum period. So now we look at systolic function. I don't know whether you do the heart scan yourself, and then, but then in the old days you have to do everything manually. But with the heart assist, the automatic tracing of the interface between the compacted myocardium and the left ventricular cavity can be achieved, as shown in this video. And then this is basically apical view. If you do fetal echo, it's the same principle. Yes, basically you go to the fifth intercostal space, and then you'll be able to point the head, point the probe towards the head, and acquire this four-chamber view. And then the ejection fraction can be automatically measured with this function. So with ejection fraction, our results are shown here. If you remember, at the beginning of my presentation, I showed you the results of the meta-analysis demonstrating that systolic function is not impaired during the pregnancy period. However, in the postnatal period, we've demonstrated that compared to the low-risk group, which is right here. The middle group is the high risk without HDP, and then the red line is high risk with HDP. Substantial reduction in ejection fraction at 6 to 12 weeks. Postpartum, you get marginal normalization by 12 months, but then still nowhere near the low risk group. So the last part of the scan is diastolic function, and this is a very standard slide to tell you what defines impaired diastolic function. And essentially, you get average of E to E prime greater than 14, septal E prime velocity less than 7 centimeters per second, or lateral E prime velocity less than 10 centimeters per second, tricuspid valve regurgitation velocity greater than 2.8 millimeter per second, and then left atrium volume index greater than 34. So this is how you define a diastolic dysfunction. I think it's quite overwhelming with all of these parameters. So with the help of a heart assist, we can evaluate the diastolic function here. And then essentially we're looking at the flow velocity across the mitral valve, and then you can see the correct placement, not above, but really just at the tip of the valves. And this is basically determined with heart assist. We can estimate the E to A ratio automatically without having to do it manually, and within seconds you get the results. That is the E to A ratio. And then we also did tissue Doppler, and then basically placing the caliper over the mitral annulus. And then during systole and diastole, we measure the E prime, A prime, etc. And previously I defined what is diastolic dysfunction, and then you can refer, I wouldn't remember all of these, but then with the help of AI, we are able to complete the whole scan in 20 minutes. And then the last, there are two more tools that I want to share with you. One is the left atrial volume. Again, this is automated, and you can take the left atrial volume in the 4-chamber view and then in the 2-chamber view, and that will be automatically calculated. And then the last is the tricuspid regurgitation velocity. And then, of course, turning on color is helpful. You can see the regurgitant jet, and then you measure the velocity, which is simply checking the PSV. Okay, so these are the 4 tools that you can use for evaluating diastolic function. In relation to our results, I want to present to you is E to A ratio, and then the low risk group was right here, normal value, and then the 2 high risk groups had a very low value at the beginning in the postnatal period, with gradual normalization by 12 months postpartum, but again nowhere near the results of the low risk group. So essentially, these are the conclusions of our work. We can implement the first trimester screening prevention of preterm preeclampsia in various parts of the world. With the use of aspirin given to high-risk women, we can effectively prevent preterm early onset preeclampsia as well as perinatal death and preterm birth, spontaneous preterm birth. And we've seen, based on our work, that there is cardiovascular malabsorption even before the onset preeclampsia in the postnatal period, which is becoming quite a hot topic because we need to think with the view that pregnancy and the postnatal period are a window of opportunity to optimize long-term health. And right now, there are no drugs that could improve the cardiovascular function. Imagine these women proceed to a second pregnancy. The starting point is much worse than before the first pregnancy. How can we optimize the cardiovascular function? And yes, we don't have the solutions yet, but at least I need to show you the evidence, convincing you that the pregnancy is a major stress to a woman's body, and therefore, having had a hypertensive complication pregnancy means that we need to proactively screen for future cardiovascular risks, as well as coming up with solutions for optimizing inter-pregnancy health, as well as preventing future cardiovascular morbidity, be it lifestyle interventions, be it a drug, maybe aspirin could be useful, maybe statin could be useful, but we need to have this, the observational data to support the need of interventions before we embark on major interventional studies. So thank you very much for your attention.